For this morning is on pediatric trauma. Okay, so I believe you already have your basic trauma lecture in general surgery from Dr. Tuazon. Okay, so parts of the lecture where it will deal on general trauma management, we will go a little quickly. Okay, but on the parts where it is very specific for pediatric trauma, then those are the points that I will be emphasizing. Okay, again, just give me a few seconds for this introduction slide. Okay, thank you for that. Okay, so warning, if you've just had your breakfast and you are a bit queasy, okay, then this lecture will have is graphically explicit. Okay, so childhood trauma is one of the poorest understood and most serious social, economic, and medical phenomena of current times. Okay, if you look at this statement, this was stated in 1966. Okay, we are already in 2021, and that statement remains painfully true up to today. Okay, so our objectives is to introduce you students to basic trauma diagnosis and management, and of course to introduce you to some basic considerations in the management specific to pediatric trauma. Okay, so accidents have been the leading cause of death among children aged 1 to 14 years old for the last 40 years. Okay, so that is why pediatric surgeons are automatically also trauma surgeons. Okay, because of this. Big bulk of our practice is on trauma patients. Okay, and for example, in Region 1, the designated trauma center is Ilocos Training and Regional Medical Center. That's where Dr. Bernabe is. Okay, but of course, the Region 1 Medical Center is also receives a lot of trauma patients. Okay, when prevention, which should be our first priority, has failed, a well-trained, responsive emergency medical system using a systematized approach to the treatment of injuries is essential. Okay, so this is the trimodal pattern of death in injury. Okay, so the first phase is when at the locality of the incident. Okay, so for example, a medical vehicular crash occurred. Okay, and we have several multiply injured patients. Then almost 50% of these patients die from the injury. Okay, so this is the reason why prevention is the very important armamentarium against trauma. Okay, so we should keep our highways safe. We should keep our home safe. We should keep our work area safe from trauma. Okay, so for the percentage of patients who uh, are alive after the first phase, okay, they go into the second phase, and at this point, it was noted that even up as high as 30% of the patients die. Okay, what is a good trauma system? Okay, a good trauma system is, of course, the first aid responders who arrive at the trauma area. Okay, the ambulances which will transport these patients from the area to a trauma center. Okay, the doctors who will be managing that patient in the trauma center acutely. Okay, so this is your trauma system. Okay, and if your trauma system is good, okay, then you will be able to save these patients. Okay, so for those who are familiar with the 911 system in the United States, that is a very good trauma system. Okay, and then the third phase is, of course, your critical care and rehabilitation. So all the patients who have been managed successfully in the trauma system, they enter into the third phase. Okay, and of course, they have to be managed appropriately in the intensive care units after the intensive care units to undergo proper rehabilitation. Okay, so that is why trauma surgeons, those who we have a subspecialty in trauma. Okay, and they also take critical care management. Okay, so they are trauma surgeons and critical care doctors as well. Okay, if you look at this graph, okay, and this is the percentage of deaths by age and by cause. This was taken in 1993. Okay, so if you look at the age groups, okay, from 1 to 4 up to around well, let's say 35 to 44. Okay, the red bar represents death secondary to trauma. Okay, death secondary to trauma. Okay, and we see that it peaks at around 15 to 24 age. Okay, so that means these are the people who are already going to school, starting their careers. Okay, so they are the one who are outside. Okay, so this represents the workforce of the country. Okay, so it goes. So trauma deaths, okay, increases up to 15 to 24. Okay, it's still high at 34. It's still high at 44. Okay. Uh, so this shows the impact of trauma on our health system. Okay, yellow is your infectious diseases. Okay, it peaks also at the pediatric ages. Okay, but then after the age 1 to 4, it seems to be stable. Okay, death from malignancy. Okay, you see here, it slowly growing. Okay, and it peaks around 45 to 64. Okay, extends up to 74. Okay, so that just shows graphically the impact of trauma on our health system. So the death rate among trauma patients, that is why we have a separate lecture on pediatric trauma. Okay, because if you compare, okay, there are more deaths in children, okay, as compared to our adult patients. Okay, so our basic trauma principles, okay, an injury as defined by the WHO is a bodily lesion resulting from exposure to an energy, okay, and this interaction with the body in amounts that exceeds the limits of physiologic tolerance. Okay, so this energy can come in different forms. They can be mechanical. Okay, this can be your vehicular crash, your falls. Okay, even your assault. Okay, they can be thermal. Our patients with burn injuries, radiation, electrical, and even chemical. So, for example, okay, you have an SUV, okay, running at even, for example, in the legal speed, okay, so 100 kilometers per hour, okay, and this interacts with a human person, okay, so you don't need to be very bright, okay, to understand how this interaction will end, okay, so definitely the human person will lose this interaction, okay, the SUV might have little dents, little scratches, okay, but the human person will definitely lose this interaction. Okay, so next, one important thing that I would like you to remember after this lecture, okay, is injuries are not accidents. Okay, so this is one concept that trauma surgeons would like us all to understand, and especially for you as medical practitioners. Okay, and why is this? Okay, so injury actually has patterns. Okay, it is predictable, it is preventable. Okay, so as I showed you in the earlier slide, when you have an interaction with a car and the human person, you already know how that will go. Okay, so it is predictable. Okay, you know that definitely the human person will lose that interaction. And more importantly, it is preventable. Okay, so for example, in the highway, if you keep, for example, barriers, okay, in the highway so that no person can cross the highway, okay, then that would go a lot into injury prevention. Okay, of course, at the side of the cars, we are implementing our speed limits. Okay, so if you go uh, at the legal speed, which is 100 kilometers per hour, you have more control of your car, so that even if a person illegally crosses the highway, you will have enough time to step on your brakes, okay, or to swerve to an area where you will not hit that person. Okay, so these are not random events. Okay, they occur in predictable patterns. Okay, so that is why one of my goals after this lecture, okay, is when we have discussions of cases like this, I wouldn't want anyone saying vehicular accident, okay, because that is not correct. The acceptable terminology in trauma circles around the world is crash, okay, so vehicular crash, not accident. Okay, if you look at the DOH health programs, okay, we have a lot of health programs, okay, immunization, national family planning, okay, but there is no specific program for injury prevention. Okay, so what are the locations where our pediatric trauma occurs? Okay, so if you look at this, okay, there was a study done on where trauma occurs, and this is very specific to our pediatric patients. So in the 1 to 14 age group, that has been shown to be where trauma occurs. Okay, majority of it happens at home. Okay, which is of course rational because most of these children are still at home. Okay, so most of these incidents happen at home. That's 48%, almost half. 33% happens in the streets. 11% in recreational areas. So, for example, the family goes to Boracay, the family goes to 100 Islands, okay, and they can have accident your injuries there. And then 8%, of course, this already belongs to the school age pediatric patients. They happen in school. Okay, so let me show you some pictures. Okay, so this is an accident waiting to happen. Okay, so that television could fall into the tub anytime. Okay, aside from its weight crashing on the children, okay, the children can get electrocuted. Okay, so we know that our children are very inquisitive. Okay, so anything that they can reach, okay, may cause injuries at home. Okay, so these children are about to be electrocuted or about to be stabbed with a scissor. Okay, and as they grow, they go to the streets, they play, okay, and they can be injured. Okay, if you were watching the news last week, November 6th, okay, you would have seen this case. Okay, so this news, okay, has sparked actually a lot of debate in the internet. Okay, because the news group here has stated that the taxi driver should be the one responsible for the safety of the child. Okay, but a lot of netizens are saying, of course not. The mother is there. The mother is responsible for the safety of her child. Okay, so personally, I believe that that is the case. Okay, I don't think the taxi driver has any fault in this. Okay, even though they say that he should have a seatbelt for the child, okay, or he should have checked for the child lock of the car. But the point is that baby is being held by the mother. So, okay, so that has sparked a debate in the internet. Okay, so when we have, of course, in this lecture, we are talking about trauma, okay, in the multiply injured patients, okay. We will not talk about minor injuries. For example, patient scratch his arm, goes to the emergency room, okay. Uh, that, of course, will not be our topic this morning, okay. So our discussion is on the approach to a severely injured patient. Okay, and we know for a fact, okay, that when we are doing our history in a trauma patient, we have what we call your abbreviated history. Okay, so we do not do your psychiatry or your family history type of history taking here. Okay, where you have to go through the anamnesis, okay, or you have to ask what is your means of garbage disposal, okay. By the time you finish your history, the patient is already dead, okay. So in surgery, we have a abbreviated history, okay. So we deal with what is potentially lethal, okay. Those are the things we concentrate on, okay, before we take a more extensive history. Okay, so in the primary survey, uh, Okay. So the abbreviated history, okay, we should remember by your DOI, TOI, POI, MOI. DOI is DOI, TOI is TOI, POI is POI, MOI is MOI. So DOI is date of injury, place of injury, mechanism of injury, DOI, TOI, POI, place of injury. Okay, so that is our abbreviated history. Okay, so we ask the patient, when did this happen? What time? Okay, because we have to take note also the number of hours it took from the time of injury until this patient is in the emergency room. Okay, of course, if the patient is there earlier, then prognosis is better. If the patient was brought to the hospital 12 hours after the injury, then prognosis might be a little less. Okay, then place of injury, where did it happen? And then mechanism of injury, that's where we ask, was this a vehicular crash? Was this a fall from a height? Was this an assault? Okay, a group of people assaulted this person. Was this a stabbing wound? Was this a gunshot wound? Okay, so these are our categories of trauma. Okay, so after that abbreviated history, we go to our abbreviated physical exam. Okay, and to remember this, okay, because we have to be very quick in the emergency room. Okay, we have our mnemonic ABCDE. Okay, so A is airway and C spine. Okay, the only thing that does not follow the alphabet here is C spine. Okay, but it should be in the first part. Okay, so airway and C spine, the cervical spine. That's very important. B is breathing, C is circulation, D is disability, and E is exposure. Okay, so the airway is the first thing that we check. Okay, because that will kill your patient in a few minutes if the airway is not controlled. Okay, and of course, the first you have to talk to the patient, and if the patient is actually able to talk, okay, what is your name? What happened? Okay, then you know that the airway is patent. Okay, so that's one of the easiest. Okay, if the patient is able to talk without any exertion of energy, okay, then you know that that airway is patent. Okay, if that is not the case, okay, then we intubate our patients immediately. Okay, so there is a saying in trauma, okay, even in, but this can be accepted in the general medical practice. Okay, it is easier to intubate. Sorry, it is easier to extubate, okay, than to intubate at a later time. Okay, so if any of this is noted, the patient is GCS 8 or less. Okay, the patient cannot talk because of an obstructed airway. Okay, physically you see that the area of the mouth, for example, it's a maxillofacial trauma. Okay, there's blood in the face. Okay, there is disfigurement of your mandible. Okay, then you intubate. Okay, patient is in hemorrhagic shock, intubate. Patient is combative. Okay, what does combative mean at this point? It's not that the patient is wearing army uniform and wants to have a square with you. Okay, it means this has something to do with poor brain oxygenation. Okay, so the patient is wagging around, okay, because of hypoxia. So in this case, you have to intubate immediately. Okay, so as I said, the C spine is the only part of this system where it does not follow the alphabet. Okay, but it has to go with A because it's very important. So when we see our multiply injured patients, okay, we have to make sure to control the cervical spine. Okay, because we know for a fact your airway tract is there. Okay, And if that is not stable, again, your patient may die in a few minutes. Okay? So if you do not have any equipment, you can actually use your hands, okay, while waiting for an equipment to come. So you can hold the patient at the shoulders, okay, just like in the picture, okay, and place, okay, your arms at the patient's on the side of the patient's head, okay, and this will temporarily immobilize the patient, okay, while waiting for an equipment. Okay, this is what we call your Philadelphia collar. Okay, so this is a soft collar, okay, but it can immobilize the neck. Okay, if you're watching several medical dramas, you can also put sandbags, okay, on the side, and this will immobilize the patient, especially when you have to transport the patient. Okay, under breathing, you have to guarantee adequate oxygenation and ventilation. Okay, so when you are observing the patient, see if the patient has chest rise. Okay, so look at the patient. Okay, make sure that the chest is rising. Okay, when the patient is breathing. So this will ensure you that the patient is breathing properly. Okay, of course, at the start, when the patient arrives in the emergency room, we give our supplemental oxygen. Okay. If you have a pulse oximeter, you can start checking. Okay. So look at the chest wall. Okay, to make sure that the patient is ventilating properly. Okay, and assess for your respiratory effort. Okay. So this is a time where the respiratory rate is very important. Okay. So if the patient is breathing more than 20 breaths per minute, okay, and there is so much effort for the patient to be breathing, okay, then we know that this patient will get tired eventually. So at this point, you can opt to actually intubate the patient. Okay. Again, you will not be faulted if you intubate early. Okay. But if you try to intubate when the patient is already very tired, okay, because patient is taking so much energy to breathe, okay, then by the time it might be too late to intubate. Okay, next in our ABCDE is circulation, okay, to assure adequate oxygen delivery and control of bleeding. Okay, so of course you assess the vital signs. You look if there are any external signs of bleeding. Okay, if it is an extremity bleeding, this all of this will succumb to your direct pressure. Okay, so put pressure on the area. Look at this first aid responder. Okay, he is wearing gloves. Okay, so at this era, okay, when you see a trauma patient being wheeled into the emergency room, you wear your gloves. Okay, because there are already a lot of your infectious diseases that can be transferred by blood. Okay, so you don't know. Okay, you will not ask in your history, do you have HIV? Okay, so make sure to always protect yourself. So direct pressure. Okay, we know for a fact, okay, that our long bone fractures, if they are not reduced, okay, they can bleed. For example, a fracture of the femur. Okay, if you do not reduce that, it can bleed into the thigh as much as 2 to 3 liters. Okay, so you cannot, for example, you cannot find an external source of bleeding, but the patient is very pale or hypotensive, then that is the source of your bleeding. So you have to reduce fractures. Here you see a patient with being considered for a pelvic fracture. Okay, so they had to immobilize the pelvis. So this is a pelvic immobilization device. Okay, so When do we transfuse blood in a patient, in a trauma patient? Sorry. Okay. So when the patient, by the time he arrives, okay, is hypotensive. Okay. So you can start transfusing blood immediately. Okay. The blood pressure remains hypotensive despite infusion of 2 liters of IV fluid. Okay. This slide is quite old. Okay. There has been a new guideline, I think last year. Okay. And now the initial resuscitation is only 1 liter. Okay. So 1 liter. So the tolerance for blood transfusion is lowered. Okay. So it means we transfuse blood earlier now. Okay. But of course, in centers where blood is not that readily available, we still use this 2 liters rule. Okay. But if you are a center with a blood bank, then you use the 1 liter rule. Okay. So transfuse the patient, get a good IV line, transfuse, fast drip, 1 liter. Patient still hypotensive, order blood transfusion. Okay. Of course, clinically, if you have a pale, very pale patient. Okay. Under disability, this is your neurologic. Okay. You assess for the Glasgow Coma Scale, assess for pulses, sensory, and motor function. Okay. So remember your GCS. Okay. Your best motor is 6. Your best verbal response is 5. Your best eye opening is 4. Okay. So remember, there is no GCS score of 0. Okay, a dead patient will have a GCS score of 3. That's the lowest. Okay, no GCS score of 0. Okay, what about an intubated patient? Okay, so usually when we hear referrals, doc, we have an intubated patient, but the patient is awake. Okay, so they say, doc, the GCS score is 10 because the patient is intubated. Okay. Of course, in trauma, okay, we can be a little more specific. And the trauma surgeons internationally has actually made a formula for this. Okay. So to compute for the V in an intubated patient because of trauma, I don't think they're using this in neurology. So this may not be used in your neurology patients. Okay, so we're talking about your trauma patients, okay, to get a better assessment of the GCS. So the V is equal to 0.5 of your motor score and 0.4 of your eye score. Okay, so for example, this patient, okay, best motor response 4, best eye opening 3. Okay, so with this formula, we get 0.5 of 4 and 0.4 of your E. Okay, so that gets us a total of 3.2. Therefore, your GCS 10 is not GCS 7, okay, but GCS 10. Okay, so you have a better assessment of your trauma patient. Okay. Of course, when we are talking about a pediatric patient, okay, the GCS, the way to get the GCS score, okay, varies only in the verbal response. Okay, so the eye opening, the motor response is the same, okay, with an adult. Okay, but of course, the verbal response is age dependent. Okay, so it is age dependent. So it's important to have this readily. Okay, you can put it on your cell phone. Okay, or if you're working already in an institution, you have a poster where you can easily get the information. Okay, and the last of your ABCDE is exposure and environmental control. Okay, if you are already under the E, okay, you have to undress the multiply injured patient. Okay, and when I was a first year resident, this is one of my favorite tasks. Okay, so I am in charge of undressing the patients. Okay, so to be able to do this, you should have a very sharp scissor, okay, with a blunt end. Okay, the blades are sharp, okay, but the end is blunt. Okay, we have scissors like that. So when a multiply injured patient arrives at the emergency room, okay, you have blood all over, okay, we do not save the clothes, okay, we cut them up. Okay, so this uh, scissor should be strong enough to cut through jeans. Okay, we know that jeans is a favorite clothing of Filipinos. So a lot of them come to the ER, okay, with the jeans. Okay, so we have to cut that up. Okay, we don't wait for the patient to remove his or her clothes. Okay, or we don't have to. It takes time to actually remove that jeans, especially if it is a very fitting jean. Okay, it will take time. So we actually cut them up. Okay, to be able to, and what is the purpose of that? Okay, to be able to observe the patient as a whole. Okay, you make sure that you see everything. Okay, so that you will not miss any injury. Okay, of course, after removing the clothes, okay, we give the patient a hospital sheet, okay, to cover him or her up so that he or she will still be warm. Okay, and then we have the concept of a log roll. Okay, what is a log roll? If, for example, you have a log, okay, what is a wood log? Okay, imagine a wood log. Okay, let me get something here. Okay, so for example, this is okay, a log, okay, the trunk of a tree. Okay, when a log rolls, what happens? Okay, the whole thing rolls. Okay, it's not only the head part that will roll and then the leg part does not. Okay, so that should be the concept. So this will take around 3 to 4 people of the trauma team. Okay, one will hold the head. Okay, one will hold the legs, one will hold the pelvis. Okay, and one person will push the patient. Okay, so the patient, okay, will be pushed to the side. Okay, the trauma team will the trauma team leader will say, let's do the leg roll. Okay, so he can either be the one pushing or he can be watching from the head part. Okay, so you will roll the patient, and the purpose of that is to also evaluate the back side. Okay, also evaluate the back side. Okay, because that is one of the most missed areas. Okay, one of the most missed areas. The backside is missed. The axilla is missed. Okay, we had a patient before with a stab wound in the axilla. Okay, the first year resident missed it. Okay, so he did not see it. Okay, and then when we did an X-ray, so we already moved the patient to the radio suite. We did an X-ray, and lo and behold, the patient had a pneumothorax in the left. So we didn't know why. So we did a re-evaluation, and lo and behold, there was a stab wound in the axillary part. So that is one of the areas that's most commonly missed. The perineum is usually missed. Okay, and of course, the back. Okay, so we have to discuss the big three. Okay, because the big three is what actually kills a lot of our patients. Okay, when you are answering questions in trauma, for example, in the boards, okay, and they will ask, what is the most common cause of death in a multiply injured patient? It's actually central nervous system injuries. Okay, a brain injury, okay, that's the most common cause of death. Okay, the second most common cause of death is thoracic injuries. Okay, and the thoracic injuries is where the big three belongs. Okay, so the big three is your tension pneumothorax, your massive hemothorax, and your cardiac tamponade. Okay, so we will go through this separately. So what is a tension pneumothorax? Okay, So it means there is air in your thoracic cavity. Okay, and this will be exemplified by a physical finding of a decreased breath sounds. Okay, so in this patient, look at the right side, decreased breath sounds. Okay, and of course the trachea will shift to the contralateral side. Okay, if you percuss, okay, there will be hyperresonance. Okay, and this is because the area now, okay, this area which should have been filled up by your lungs is now already very small. The lung on the right is now very small. Okay, so you get your mediastinal shift, therefore you will have decreased venous return. You have decreased end diastolic volume, therefore your stroke volume and your cardiac output is decreased and your patient becomes hypotensive. Okay, so your tension pneumothorax is of course the worst version of your simple pneumothorax. Okay, your simple pneumothorax, you just have air in that area, but it will not cause this physiologic shift. Okay, but if it's already too great, then you have your tension pneumothorax. Okay, so this is a simple pneumothorax. Okay, you look here, you can see the margin of the lungs. Okay, you can see the margin of the lungs. Okay, and beyond that, that's already air in your thoracic cavity. Okay, this is a patient with a tension pneumothorax. Okay, you see the heart is already pushed to the other side. This is already, okay, free air. Okay, and you see here, okay, patient has rib fractures. So this patient is victim of a vehicular crash. Okay, I would tell you that in the real world, an X-ray of a tension pneumothorax shouldn't be available. Okay, what does that mean? It means tension pneumothorax is a clinical evaluation. Okay, so when you have a patient who arrives in the emergency room, patient is hypotensive, you should check for the chest immediately. Okay, for example, you don't have any external signs of bleeding, you don't have any fractures, then you know that bleeding is not the cause. You should also check for the lungs. Okay, and if you have decreased breath sounds, it's hyperresonant, and the patient is hypotensive, you already have the components of a tension pneumothorax. Okay, so don't bring that patient to the radio suite. Okay, majority of emergency rooms have the radio suites far from the emergency room. Okay, so this X-ray the possibility for this X-ray is probably the X-ray suite is very near the emergency room, or they had a portable X-ray, so they were still able to get an X-ray. Okay, so remember that. You don't need an X-ray to diagnose tension pneumothorax. And if you diagnose tension pneumothorax, okay, you should immediately take action. Okay, the management is to put in a chest tube. Okay, immediately. If you don't know how to put a chest tube, for example, you're just a clerk at that time. Okay, all the residents are busy looking at other patients, or for example, there were 10 trauma patients wheeled in, okay, and you are the 10th team in the member of the team, sorry, and the one that was assigned to you has tension pneumothorax, you can do your needling. Okay, you can do your needling. Okay, so this is called your needle thoracostomy. Okay, this is not actually a good picture. Okay, the best place to put your needle if you are going to do a needle thoracostomy is at the second intercostal space, mid-clavicular line. Okay, second intercostal space, mid-clavicular line. Okay, of course, this is still possible. Okay, if you have to consider, uh, okay, if you have to consider this picture, actually you can put the needle anywhere if this is the case. Okay, but the safest is the second intercostal space, mid-clavicular line. Okay, so you remember that because you might be able to save a life later on. Okay, but the needle thoracostomy is not the end-all treatment. Okay, so do your needle thoracostomy and then tube thoracostomy must be placed later. Okay, because the needle, okay, even though you have a very large bore needle, okay, of course you will need a larger uh, tube for the air to come out. Okay, so what is the second in the big three? This is your massive hemothorax. Okay, again you have decreased breath sounds, tracheal shift. Those are the same things that are happening in a tension pneumothorax. Okay, but this time instead of air filling up that space, it's blood. Okay, that's why it's called hemothorax. Okay, and it is rational now that because this is no longer air, this is now fluid. When you percuss, okay, it's no longer hyperresonant. It's already dull, okay, because of that fluid. The same physiologic changes occur, okay, but because you are also losing blood, okay, you are also one other factor that causes your hypotension is not just your decreased cardiac output, okay, but of course also due to your hypovolemia. Okay, so double whammy in massive hemothorax. So you have hypotension because of the restriction of the blood in the thorax, and you have hypovolemia. Okay, so this is a patient with a massive hemothorax in an X-ray. Look at the heart; it's already pushed to the other side. Okay, again, massive hemothorax is a clinical evaluation. Okay, if you miss this, it's possible that the patient will die in a few minutes from respiratory incapacity. So again, a picture of a massive hemothorax should not be present in the real world. Okay, unless again you have a portable X-ray in the emergency room. Okay, and you were able to get an X-ray immediately. Okay, but you cannot bring a patient who is hypotensive to the radio suite. Okay, you have to deal with the hypotension first. Okay, and if the hypotension is secondary to a massive hemothorax, then you have to put a chest tube immediately. Okay, so if you look at it, okay, if you have a patient with decreased breath sounds, patient is hypotensive, okay, the treatment is the same. It's insertion of a chest tube. Okay, so even if at the start you are not very sure, is this tension pneumothorax? Is this massive hemothorax? Okay, it's the same. Okay, you put a chest tube. Okay, and if you are correct, that will significantly change the course of your patient. Okay, so the last of the big three is your cardiac tamponade. Okay, so this time the thoracic space is okay. Okay, thoracic space is okay. Now you have what we call your pericardial sac here. Okay, we know for a fact that there is minimal fluid in there, serous fluid. Okay, and that fluid helps the heart beat. Okay, so there's a normal amount of fluid there. Okay, but if that pericardial sac is filled with blood because there is an injury to the heart, okay, so it can be secondary to a stab wound, secondary to a gunshot wound, okay. The worst case is secondary to a blunt trauma, okay. So for example, the patient is a driver not wearing his seatbelt, okay. goes into a vehicular crash, hits his chest uh, in the manibela, okay, or the driver's gear. Okay, so the patient will have a blunt injury to the heart. So it will start to bleed into your pericardial sac. Okay, so this is you will have decreased cardiac filling again and diastolic volume, decreased stroke volume, decreased cardiac output, and blood loss. Okay, but the blood loss in cardiac tamponade is not that massive like in a tension in a massive hemothorax. Okay, you only need a smaller amount. Okay, because the pericardial space is smaller. Okay, to be able to cause your cardiac tamponade. Okay, so the treatment is just like in your thoracic problems. You have to make sure to drain. Okay, drain the pericardial space. So this is two maneuvers for pericardiosynthesis. Okay, for trauma surgeons, we actually are able to do this. Okay, because this is easier. You access the pericardial sac from the subxiphoid area. Okay, this usually this is being done by our cardiac surgeons. Okay, for trauma, this is we teach this to our residents. Okay, this is easier to do. Okay, it achieves the same goal. Okay, of course, and then after that, you bring the patient to the operating room. Okay, um, in some cases, okay, we have what we call a patient who arrives at the emergency room. Okay, and then initially, for example, the frontliners, okay, or the first aid responders who brought the patient said, Doc, this patient had a BP of 70/40 in the scene, okay, uh, but now I think the BP is around palpatory 20, okay, the pressure, okay, and when you checked, okay, the patient is still opening his eyes, okay, and then in a few minutes the patient uh, goes into arrest, okay, so that is what we call a witnessed arrest. Okay, that is a witnessed arrest. Okay, and this is different from a patient who is DOA. Okay, so when a patient arrives in the ER and then you evaluate the patient is already dead, you declare that patient DOA, dead on arrival. Okay, but if the patient still has signs of life when the patient arrives, and then when within a few minutes the patient arrested, okay, we call that a witness arrest. Okay, and in cases like that, okay, and especially for your penetrating injuries, okay, so injuries secondary, for example, to a stab wound, secondary to a gunshot wound, okay, this is what we call your penetrating injuries. Okay, your blunt injuries are injuries secondary, for example, to a car crash, to falling, to mauling. Okay, those are different. Okay, so studies have shown that your emergency department thoracotomy, okay, so your ED thoracotomy, as you can see from the picture here, okay, your ED thoracotomy has a distinct advantage in penetrating injuries. Okay, it has a distinct advantage in penetrating injuries. Okay, so what does ED thoracotomy mean? Okay, emergency department. So you don't need to bring this patient to the operating room. Okay, the operating room can be far. Not all emergency rooms have an adjacent operating room. Okay, so you do the procedure in the emergency room, in the emergency department. Okay, so what we do is So this is like end treatment. Okay, you have no other treatment available, so you have to do this quickly. Okay, so we prep the chest. Okay, prep the chest immediately, and then open up the chest. Okay, you don't need local anesthesia. The patient is already arrested. Okay, so you don't need no local anesthesia. You do a wide chest opening. Okay, you put your rib retractors here. Okay, so that is a rib retractor. Okay, and then when you have done that, you have access to the thorax. You have access to the heart. Okay, so for example, you have a injury to the lungs. Okay, you can actually hold that part. Okay, to stop the bleeding while waiting for your other teammates to prepare sutures so you can start suturing the lungs. Okay, or if the injury is to the heart, you can open the pericardial sac. Okay, and do um, and repair the heart. Okay, so in trauma situations, trauma surgeons can do this. Okay, you don't need to call a cardiac surgeon. Okay, trauma surgeons can do this. Okay, and this is my last edithoracotomy. Okay, when I was still senior in the Philippine General Hospital. Okay, uh, of course, I have not had a case of an ED thoracotomy here in Region 1 Medical Center. Okay, but we had a case of a cardiac injury probably 2, 3 years ago. Okay, where we were able to bring that to the operating room. Okay, but the definition of your ED, emergency department thoracotomy, is you actually do it in the emergency room. So this can be a life saving event. Okay, but again, remember, it is the benefit is more for your penetrating injuries. Okay, for your blunt injuries, for example, the patient was hit by a car. Okay, and you had a witness arrest. Okay, prognosis is actually very bad. Okay, so the big three, remember, your tension pneumothorax, your massive pneumothorax, and your cardiac tamponade. Okay? And here are some possible distinguishing factors. Okay? So, of course, your tension pneumothorax will be hyperresonant, and your massive pneumothorax will be dull. Okay, your cardiac tamponade, you would have muffled or your distant heart sounds. Okay. What are other clinical scenarios? Okay, we call this your flail chest. Okay, what does a flail chest entail? Okay, you have multiple rib fractures. Okay, like in this picture, 1, 2, 3, 4. Okay, but uh, the fracture is so 2 points. Okay, not just multiple rib fractures, but on 2 points. So you have here an anterior rib fracture, and if you follow it, there's also a posterior rib fracture. So what happens? You have an island. Okay, you have an island of chest wall that has been separated from the main. Okay, and physiologically, what this will do is that every time the patient breathes, okay, instead of the chest going out, okay, or maxing out like that, because there is now this island, okay, that is separate, it actually goes in. Okay, so here in patient tries to inspire, okay, the other walls expand, okay, but this island goes down. Okay, so you have a restrictive problem. Okay, you have a restrictive problem. Okay, in the past, what they did was they put, okay, they access those broken ribs, they put pins, okay, and then they tie it to the bed. Okay, they tie it to the bed like that. Okay, that, of course, that's in the past. Now, we can do these titanium plates. Okay, so that you put titanium plates over the fractured ribs. Okay. Another one is your pulmonary contusion. Okay. Contusion is a generic term in medicine. Okay. So if you look at this X-ray, there seems to be a mass here that's white. Okay. This is a plain X-ray. Okay. There's no dye that was introduced to this patient. So you seem to have this mass here. Doc, how is this different from massive hemothorax? Okay, you know that this is not free blood in the thorax, okay, because you can see your costophrenic angle. Okay, costo, rib, phrenic, diaphragm. Costophrenic angle is clear, okay, meaning there's no blood there. Okay, so if you have blood in an upright film, it should level. Okay, just like the massive hemothorax X-ray we had earlier. This time, it looks like a mass here. So that is probably where the impact, okay, of blunt trauma is. Okay, so if you have a pulmonary contusion, you will also have a patient who might be in respiratory distress. Okay, so treatment for this is of course non-surgical. Okay, just like in any contusion, for example, you have a soft tissue contusion. Okay, what do? We just put a warm compress, right? In a pulmonary contusion, of course, we cannot do a compress. Okay, but we monitor the patient. Okay, if in case the respiratory distress progresses, then we might have to intubate the patient. Okay, otherwise it's supportive. Okay, so you can have cases of a massive pulmonary contusion, but there are no fractures. Okay, and this is especially true for your pediatric patients. Okay, why? Because the skeletal system of pediatric patients are still very pliable. Okay, they are more flexible than the adult bones. Okay, so it's possible when the ribs took the impact, okay, they just moved, okay, but they were not fractured. But if you look at the soft tissue injury, it's quite massive. Okay, so no fractures, okay, no fractures, but we have pulmonary contusion. Okay. So of course, in trauma management, you also have to know how to compute for the total blood volume. Okay, and can you remember from your physiology? How do you compute for the total blood volume? Dr. Dayan Eris Valo. Do you remember?
Not so sure.
Not so sure. Okay, this is my word work student, Mildred. A, B, C, D, or E?
E po ba?
E. Okay, let's see. Okay, so we know that the 70 kilogram man, okay, 60% of him is water. Okay, the intracellular fluid, okay, is around 28 liters. The extracellular fluid is around 14 liters. Okay, your ECF is further divided, okay, into your blood, okay, which is around 5 liters. Okay, so the average volume of blood in an adult patient is around 5 to 6 liters. Okay, so that's why if your first aid responder will say, Doc, this patient lost around 5 liters in the field, okay, then you know that this man is almost out of blood. Okay, so probably the only fluid running through his blood vessels now are the IV fluid that the first responders placed. Okay, so more or less around 5 to 6 liters for the adult patients. Okay, what is the ideal resuscitation fluid? Aliana,
Doc, is it letter D po?
letter D, plain LR. Is that your answer?
Yes po, Doc. Very much.
Okay, let's ask Dr. Shekinah Suzette.
Letter D din po, Doc. Plain
Letter
LR.
D also. Aliana is your best friend, eh? Last, Windy, are you here? Windy.
Yes po, Doc.
Okay, what do you think?
Same po, Doc.
Letter D also. Okay, was this already lectured by Dr. Tuazon? Okay, last. Can we have Dr. Collado?
Letter D rin po, Doc.
Okay. So very good. Okay. So the ideal resuscitation fluid for our trauma patients, okay, and this is true even for the pediatric patients, okay, but sometimes I get into trouble with some pediatricians, okay. So for example, there's a pediatric trauma patients, I order plain LR and they say, why do you use plain LR? We should have D5 containing, okay, because these are children, okay. So there are some differences in the idea of management, okay. But where we are coming from is that in a multiply injured patient, okay, we would like to give the first fluid as a bolus, okay. So for example, a patient comes in hypotensive, adult patient, we give 1 to 2 liters. Okay. For our patients, we give 20 cc per kilogram. Okay. So remember that value. 20 cc per kilogram. You can give that as much as 3 times. Okay. So for example, the patient is 10 kilos. Okay. You compute 20 cc per kilogram. That's 200 cc. Okay, so you can give your bolus of 200 cc immediately. Patient is still hypotensive, give another 20 cc. Patient still hypotensive, give another 20 cc. Patient is still hypotensive, then start getting blood. Okay, start getting blood. And what is the reason why we give plain LR? Okay, so if we look at the different components of your commercially available fluids, okay, we have D5 water, D10 water, zero point 0.9 NSS or your plain NSS, plain LR, okay, NMNR, okay, so all these other special fluids. Okay, if you look at their components, okay, your D5 of course only has glucose. Okay, we have your D5 and then your zero point 0.9. This is they say one of the more isoosmotic fluids with a D5 containing, okay, so 50 grams of glucose, 154 sodium, 154 chloride. Okay, your plain NSS and your plain LR, okay, so your plain NSS has 154 sodium and chloride. Okay, your LR 130, 109. Okay, if you look at it, this is the electrolyte picture of our plasma. Okay, so the isoosmotic commercially available fluids are your NSS and your LR. Okay, NSS and LR. Okay, they are very near. They are very near the electrolyte picture of our blood, of our plasma. Okay, but the reason why plain LR is better, okay, because you have additional components. Okay, one of that is potassium. Okay, and the other is your bicarb. Okay, so we know for a fact. Okay, we know for a fact if they ask you in your boards. Okay, What is the most common cause of metabolic acidosis in a surgical patient? What is the most common cause of metabolic acidosis in a surgical patient? Okay, can we ask our class presidents?
That would be I think the most common cause of acidosis is at the CO2 levels.
No. China. Can I call on Randolph? What is the most common cause? Okay, so I would like to take a little longer with this part. What is the most common cause of metabolic acidosis in a surgical patient? Okay, we're talking about a surgical patient, so we're not talking about renal problems. Okay, we're not talking about kidney disease here. Okay, and usually, of course, who are our trauma patients? Our trauma patients are healthy individuals. Okay, because you do not expect a patient who is on dialysis, walking on the streets, and suddenly gets into a vehicular crash. Okay, so who are the patients who become victims of trauma? These are the healthy individuals. Okay, so who can go to the beach, for example, and then drown? These are healthy individuals. You don't expect a stage 4 renal disease patient swimming in the beach. Okay, so that is why the question clarifies what is the most common cause of metabolic acidosis in a surgical patient or in a trauma patient.
Hypovolemic.
Very good. Okay, it's hypovolemia. Okay, so a trauma patient who loses a lot of blood in the trauma scene, okay, goes into metabolic acidosis, okay, because the hypoxia that is caused by the decrease in blood volume, okay, so the body now goes into anaerobic energy production. So you remember that in your physiology, okay? So the patient now goes into your anaerobic energy production. Okay, so this brings out a lot of acid byproducts. Okay, so your patient goes into lactic acidosis. Okay, so that is why your bicarb in your plain LR actually helps. Okay, in mitigating that metabolic acidosis. So this is the reason why LR is our ideal management. Okay, so for example, in a pediatric patient, I would give LR first, okay, and then when the patient is stable, then that's the time I would shift to a D5 containing. Okay, and what is the another reason why we do not use a D5 containing fluid in resuscitation? What is another reason why we don't use a D5 containing fluid in our resuscitation? Remember, in resuscitation, we give this in bolus. Huh? Not, you don't give it over 12 hours. Okay, if you give it over 12 hours, by the 12th hour, your patient might already be dead. Okay, we give it in bolus. Okay, meaning it's fast drip. Okay, you we actually use large bore needles. Okay, large bore needles, not your gauge 24. Okay, not your gauge 26. Okay, if we have gauge 18, gauge 16, gauge 14 even, okay? So that, excuse me, so that when we give the fast drip, okay, that fluid will go into the intravenous space very quickly, okay? So let's ask anyone so that I don't need to call anyone.
Doc,
What is,
can I try to?
yes, of course, try.
Doc, is it because of the content of the fiber in and yung large volume po ng glucose containing IV solutions do not effectively expand the intravascular compartment because it can result to hyperglycemia and secondary osmotic diuresis po.
Okay, very good. That's actually the answer. Thank you, Aliana. Okay, so remember when you give your D5 containing, okay, this actually causes osmotic pull. Okay, it causes an osmotic pull. Okay, and it will pull more water. Uh, Initially, it will pull more water into your intravenous space, but what happens? You will urinate this. Okay, that is your osmotic diuresis. Okay, you will actually urinate that. Okay, and remember, one of the things that we use to monitor if we are doing a good job in resuscitation is your urine output. Okay, so we put a Foley catheter. Okay, if we are sure there is no injury into the urinary tract. Okay, we put a Foley catheter and we monitor the urine output. Okay, if the urine output is within normal, then it means we're doing a good job in resuscitation. Okay, but if you give your D5 containing, okay, it will give you a false uh, volume in your urine output. Okay, so the nurse will say, "Doc, we're urinating. We have a lot of urine output." Okay, in fact, doc, it's way beyond the what you've written as 30 cc per hour. Okay, it's around 200 cc per hour. Okay, and lo and behold, your patient is diuresing. Okay, and that means your patient is actually dehydrated. Okay, your patient is actually dehydrated. Okay, and you're not doing a good job in resuscitating. Okay, so that is the reason why we use plain LR for our acute resuscitation. Okay, for pediatric patients, I still use it in the acute. And then when the patient is more stable, that's when I shift probably to your D5.9 or to your D5NM. Okay, so please take note of that difference. Okay, so when we are finished with the primary survey, okay, so you did your primary survey in the emergency room, okay, and the patient is stable, you now go to your secondary survey, okay. And here to remember the components of your secondary survey, we have our ample history, okay. So take note of allergies, okay. Remember, even your allergies can modify the prognosis of your patient. What medications the patient is taking, what are the past illnesses, okay? Does this patient have a cardiac disease? Does this patient have diabetes? Okay. What was the last meal? And what are the events preceding the incident? So that's your ample history. Okay. So after your ample history, this is now the time to do your detailed, meticulous head-to-toe examination. Okay, remember the physical exam that we did earlier? Okay, during the primary survey, that's abbreviated. Okay, we just check. Okay, for so we disrobe the patient to check if there are any signs of injury. Then lag roll to check for the back. Okay, but when we go to our secondary survey, we now do a detailed, meticulous head-to-toe exam. We insert the finger in tubes in all orifices. Okay, So this is the time that we insert our Foley caths, okay, to monitor urine output, okay. If we need to insert orogastric tube, okay, but not all will need an orogastric tube, okay. Look, listen, and feel everywhere, okay. And what are the things to look for? Of course, bleeding, if there are any open wounds, any tenderness, any deformities, limitations in the range of motion, changes in sensorium, neurologic deficit. Okay, so remember that external injury does not correlate all the time with internal injury in blunt trauma. Okay, this statement is true for adults, okay, but specifically for pediatric patients. Okay, specifically for pediatric patients. Okay, and I will be telling the reasons why later, especially for the pediatric patients. Okay, so also remember this list. Okay, remember this list. Okay, uh, the question for this list is, when do we expect a patient to have severe injuries, or when do we expect a patient to be multiply injured? Okay, so meaning if you get from the history any of this, then you have to work up your patient completely. Okay, you have to do a complete workup. Okay, because there is a very big possibility that this patient would be multiply injured. Okay, what is number one? Ejection from an automobile crash. Okay, so you have a patient, okay, and then there was a vehicular crash, car versus car, for example, okay, and then your first responder tells you, Doc, we actually retrieved the body of this patient 10 meters away from the site, and the windshield was broken. Okay, can you imagine the impact? Okay, patient broke through the windshield, okay, and was found 10 meters away from the vehicular crash site. So you would expect this patient to have multiple injuries. Death in the same passenger compartment. Okay, Doc, this patient, we found him inside the car, but the driver is dead on the scene. Okay, so that means trauma will not choose, okay, which patient will he give more impact to. So these two patients had the same, were exposed to the same energy. Okay, it's just that possibly for some reason the driver died or the passenger died and one survived. So again, the survivor you have to check for possible injuries, multiple injuries. Patient was pedestrian, was thrown or run over. Okay, high speed auto crash. Okay, uh, so if you look here, high speed is already defined at 60 kilometers per hour. Okay, if you are driving, if those of you who are driving, okay, and you drive in Skyway 3, okay, has anyone tried driving in Skyway 3 already? Not one yet. Okay, Skyway 3 is uh, connecting NLEX, okay, North Luzon Expressway, to South Luzon Expressway. Okay, it connects NLEX to SLEX. You don't need to go through EDSA, which we know is very traffic. Okay, but although it's very convenient, the speed limit is 60. Okay, and if you are driving at 60 kilometers per hour and you are akin to driving at around 80 to 100 kilometers per hour, you'll get very bored. Okay, driving at 60 kilometers. Sometimes your feet will even ache because you are trying to control the speed at 60 kilometers per hour. Okay, You see, it seems very slow, okay, but when you actually hit someone at that speed, okay, there's already a possibility of a multiple injuries. So what more if the patient came, for example, from T-Plex, where the speed limit is 100 kilometers per hour, but we know for a fact that because there are less cars there, some cars go as far as 140, 160, okay, 180 kilometers per hour. Okay, and if they hit someone, there is this stupid person who tries to cross T-Plex, and there are sometimes we see people crossing T-Plex. Okay, uh, sometimes one time I was even there was a person trying to ask me to slow down, okay, because there were goats in the highway. Okay, there were goats crossing the highway. So can you just imagine that? So the cutoff is 60. If you are driving at 60, you hit a person. Okay, that person you have to check for multiple injuries. Okay, if a person falls from a height of 20 feet, okay, so if a person falls from around 10 feet, of course you can imagine injuries are not that massive. Okay, but if the person falls more than 20 feet, that's a reason to do a full workup. Okay, bike crashes where the rider is separated from the bike. Okay, so some examinations that may be useful. Okay, if you look at this slide, I put a question mark under CBC. Okay, I put a question mark under CBC. Okay, and in trauma, okay, requesting for a CBC is not useful. Okay, it is not useful. Okay, especially when we receive patients and the time of injury is less than 4 hours. Okay, so for example, when we're doing our doi toi poi moi, okay, time of injury 1 o'clock, 1 p.m., and it's just 2 p.m. So we put time of injury 1 p.m. and then patient arrived 1 hour post injury. Okay, so a CBC at this time is not needed. Okay, even if the patient lost 5 liters of blood in the trauma scene, okay, if you check for the CBC, okay, your hemoglobin and hematocrit would still be normal. Okay, it would still be normal. And according to studies, okay, it will take around 4 hours, okay, before your CBC will reflect the acute blood loss. Okay, it will take 4 hours. So if your patient arrived within 4 hours, do not request CBC. Okay, so any decision, for example, do I need to transfuse blood? That decision will be based on a clinical evaluation and not the CBC. Okay, so remember that. Okay? It will not be based on the CBC, but on how the patient present. Patient is hypotensive. Patient is very pale. Okay, then you give blood. Okay, do not wait for the CBC. Okay, because even if the patient is very pale, hypotensive, you get the CBC. Hemoglobin and hematocrit will be normal. Okay, until after the 4th hour of injury. Okay, of course we get blood typing because um, when the time comes that you need to transfuse, okay, you will have to cross-match your blood. Okay, the reason that we get urinalysis is we check for occult blood, okay, or gross blood if that is what it shows, okay. So it means there might be an injury to the urinary tract, okay. Among the X-rays, okay, what are the routine? Okay, among the X-rays, your chest X-ray and your pelvis, those are routine. Okay, so there are only 2 routine X-rays that we request: the chest and the pelvis. Okay, all other X-rays will be on a need basis. Okay, for example, patient comes multiply injured. Okay, you're done with your primary survey, you're done with your secondary survey. Patient is stable enough to be brought to the radio suite. Okay, so the only routine are chest and pelvis. Okay, but for example, the patient has a deformed right upper extremity. Okay, of course, before bringing that patient to the X-ray suite, you you stabilize that fracture first. Okay, and then you now request for a upper extremity X-ray. Okay, that's when you request an upper extremity X-ray. When doing request for a cervical X-ray, there are also indications. Okay, is the patient feeling any pain in the cervical area? Okay, then we request for a cervical X-ray. Okay, is the patient quadriplegic now? Previously not quadriplegic, but now there's some plegia, either all extremities or just the upper extremity or just the lower extremity. Okay, then we request for a cervical X-ray. Okay, so not all patients will have a cervical X-ray. Okay, the ultrasound or 2D echo when we are suspecting a cardiac injury. Okay, that is of course not cardiac tamponade, okay, but something lesser than a cardiac tamponade. We request for a 2D echo. Uh, if we suspect an injury to the abdomen or to the chest, okay, but patient is presently stable, then we request for a CT scan with contrast. Okay. If we suspect an injury to the head, okay, we do a CT scan, but that is plain. You don't need to put contrast into the brain. If there's an acute bleed, it will light up. So remember, acute blood is white in CT scan. Okay, so you don't need to request for the CT scan of the head. You don't need to request for contrast. MRI if needed. Diagnostic peritoneal lavage is a classic, meaning it was being done before, but presently it no longer being used in practice. Angiography, okay, it depends. Again, this is not routine. Okay, it will depend on the injury that you are thinking of. Okay, duplex scan, again, not routine. Okay, and then FAST. What is FAST? Okay, FAST is focus abdominal sonography for trauma. Okay, focus abdominal sonography for trauma. Okay, and what is FAST? This is a surgeon administered ultrasound. Okay, when I was still in the Philippine General Hospital, the Department of Surgery have their own ultrasound machine, and it's there in the emergency room. Okay, so that we can do the FAST in our trauma patients. Okay, when is FAST indicated? So when a patient comes, okay, you're thinking of an abdominal injury, okay, but when you palpate, when you are finished with your physical examination, you're not sure. Okay, so the indication for a FAST is in a patient with an equivocal. Okay, so the term is equivocal injury to the abdomen. Okay, so meaning it can be positive, it can be negative. Okay, but the signs and symptoms does not tell you it does. Okay, so the focus assessment with sonography for trauma will check, okay, if there are free fluid in the abdomen. Okay, and of course, a free fluid will tell you that there might be bleeding or there might be free intestinal fluid there. Okay, so if you have an equivocal patient and you did FAST and it is FAST positive, there's positive fluid, okay, then that patient will go to the operating room. Okay, so it becomes a decision tool for a patient with an equivocal. Of course, if the patient already has clinical signs of peritonitis, then you don't need your fast. Okay, you bring that patient immediately to the operating room. Okay, so after you're done with your primary survey, secondary survey, your diagnostics and imaging, so you now make a decision: is this patient surgical? Is this patient non-surgical? Okay. If the patient is non-surgical, you can bring to the ICU for monitoring or even in the regular ward. If the patient is surgical, then of course you bring the patient to the operating room. And your exploratory laparotomy is actually part of your resuscitation. We've talked about your ED thoracotomy, that's part of your resuscitation. Your pericardiocentesis, your chest tube insertion. Okay, this is an X-fix. Okay, here we call on our orthopedics friends. Okay, this patient has a pelvic fracture. Okay, so they fix the pelvis so that it is stable. Okay, and of course you need a good IV access. What are the don'ts? Okay, do not insert an NGT in a patient with suspected facial fracture. Facial, not fascial. Facial fracture. Okay. So patient has a maxillofacial injury. Okay. Plenty of blood in the face. Okay. Do not insert an NGT. Okay. And why? Okay. We've seen some rare cases where the patient has a skull fracture. Okay. Patient has a skull fracture and the NGT went inside the brain. Okay. Do not remove impaled objects. Okay. If you see a patient come in with, for example, a knife still stuck there, do not remove it. Okay. In fact, what you should do is stabilize it. Okay. So that it can be X-rayed or imaged. Okay. And then that impaled object will be removed in the operating room. Uh, the group of Dr. Dalisay, okay, I've seen in your ward work, there was a patient with an impaled scythe in the head. Okay, so the management was correct. Okay, they did not remove the scythe immediately. They were able to image it. Okay, and they will bring that patient in the operating room with that scythe. Okay, but of course, make sure to stabilize it. Okay, we should remove the impaled object under direct vision. Okay, do not forget to warm the patient, especially children. Okay. Do not insert a Foley catheter in a patient with a suspected urethral injury. And how do we suspect urethral injury? When we are doing our physical exam, if there is blood in the meatus, in the urethral meatus, suspect a urethral injury. Okay? If the pelvis is fractured, remember, especially in males, okay, the urethra passes under the pubic tubercle, okay, under. So if the pubic tubercle is fractured, okay, or any fracture in the pelvic ring, okay, that urethra can be injured. So if that's the case, do not insert a Foley cath. Okay, you will worsen the urethral injury. Okay, do not overlook the perineum back and axilla. Okay. So what else? So what should you do? Of course, primum non nocere, first do no harm. Splint patients where they lie. If you think there's extremity fracture, put a splint. Okay. Comfort the patient, alleviate the pain. Of course, improve your skills. You study your lecture in trauma, okay, and ask for help. Okay, so trauma management is actually a team management. Okay, we have what we call a trauma team. Okay, and just like in the earlier picture which I showed you, okay, So sometimes we call on our other friends, like we call for our orthopedics friends? Do we call for our neurosurgery friends? Do we call for our maxillofacial injuries are the expertise of our plastic surgeons. Okay, of course, bone and spine injuries are orthopedics, CNS and spine neurosurgery. Okay, then we can call them. Okay, so majority of injuries can be diagnosed through an ample history and a thorough physical exam. So interventions are usually basic. Okay, so here are some principles that are very specific to trauma. Okay, to pediatric trauma. After the first year of life, trauma is the most serious pediatric health problem in the U.S. 50% of pediatric deaths after the first year of life are due to trauma. Okay, in the U.S., 22 million children are injured each year. Okay, so what are the major differences? Okay, of course, your pediatric patients have a smaller body size. Okay, and if you have a small body and a big body, okay, when the same force of energy strikes both of these bodies, okay, energy dissipation, okay, is bigger in the adult patient because there's more area to which the energy dissipates as compared to a pediatric patient. So this is the reason why we have more deaths in children secondary to trauma. Okay, body proportion. Okay, we know for a fact that children have larger heads. Okay, they have larger heads, so this increases the risk of head injuries. Okay, from falls. Okay, and your motor vehicular crashes. Okay, that should be MVC, not MVA. Okay, so children suffer abdominal thoracic head trauma from your motor vehicular crashes. Okay, can you imagine that? Okay, child, okay, standing like this, okay, and then an adult would be taller like this. Okay, so if a car hits both of these, okay, it's possible the car will just hit. For the adult, the car will just hit probably the lower extremities and the pelvis, okay, if it's a low car. Okay, but for the child, it will hit what? It will hit the legs, it will hit the pelvis, it will hit the abdomen, it will hit the thorax. Okay, so that is what that means. Okay, so larger body surface area, mass ratio. Okay, therefore you have increased heat loss and increased water loss. The large head is a very obvious target for injuries. Okay, the skull is thin and the cranial bones are compliant. Okay, you have less protection of the brain, more impact to the brain. Acute diffuse brain swelling is more common. Okay, fontanelles and sutures remain open until an average of 16 months. Okay, this this gives a theoretical advantage, not a disadvantage. Okay, so what happens if you still have open fontanelles and sutures? Okay, infants initially may be more tolerant to increased ICP. Okay, but of course the other side of that is that you would be thinking, oh, this patient is stable. Okay, it's already the second day post-injury and there are no signs of increased intracranial pressure. Okay, but only to find out that on the third day, that is when the patient becomes toxic. Okay, so initially it is an advantage, okay, because the patient can tolerate an acute increase in the ICP. Okay, but later on, you will have delayed signs. Okay, the cervical spine. Okay, because of the larger relative mass of the head, okay, the lack of muscle strength, okay, the fulcrum of cervical mobility in a child is at C2, C3. Okay, in an adult, it's C5, C7. Okay, so that's a major difference. Okay, so C2, C3. So when we are evaluating cervical imaging. Okay, if this is a child, we should look at the C2, C3 more. If it is an adult, we should look at the C5, C7 more. Okay, so this difference provides more momentum in acceleration, deceleration injuries that results in greater stress to your cervical spine. Okay, so because the fulcrum is here, okay, 60 to 70% of pediatric fractures occur in C1, C2. Okay, and C1, C2, as we remember, okay, is not a regularly shaped uh, bone. Okay, they are not. The shape is different from the rest of your vertebra, so it will be harder to actually fix them. Okay, and then your pediatric patients have a compliant elastic pediatric skeleton. Okay, and what is the disadvantage of that? Okay, you see a lot of patients. Okay, with no external signs of fracture. Okay, but the soft tissue injury can be massive. Okay, so because in the adults we usually look for example, we look for a rib fracture and then it will have an associated pulmonary contusion. Okay, but for a pediatric patient, that may not be the case. If you look at it, there are no fractures. Okay, but the soft tissue injury is more massive. Okay, what else? Pediatric patients have a smaller tracheal diameter. Okay, and that means, okay, of course, even our anesthesiologists will tell you this. Okay, it is harder to intubate a child. Okay, it is harder to intubate a child, and uh, because it is smaller, it is easily obstructed. Okay, so for a patient with a maxillofacial injury, even a small amount of blood, okay, can actually obstruct the tracheal diameter. Okay, so this is one area where an early intubation, okay, may be more advantageous than to an adult patient. Okay, because if you intubate early, okay, and prevent, for example, tracheal edema, okay, then you have saved the child. But for example, you wait for a while, okay, and then the trachea is now edematous, so that will make your intubation more difficult. Okay, that will make your intubation more difficult. Okay, what are the other factors? You have a larger tongue but a small mouth. The epiglottis is less stiff. The larynx is more cephalad. The trachea is shorter and more anterior. You have a large volume of lymphoid tissue. The gums are more vascular and therefore bleed easily. Okay. Children with who are just beginning to have teeth, okay, this can be easily dislodged. Okay, this can easily be dislodged and obstruct your trachea. Okay, and then you can also have what we call your post-trauma gastric dilatation. Okay, so here is a picture comparing the adult and the pediatric airways. Okay, so in the uh, pediatric patient, the occiput is more prominent. Okay, so if you already have your anesthesia lectures, okay, this what did anesthesia tell you in the adult? Okay, your chin lift, okay, head tilt, and then chin lift. Okay, in the pediatric patient, okay, that's more difficult to do because you have a larger occiput. Okay, and you actually have to move the patient a little more as compared to your adult to be able to identify the airway. Okay, the narrowest portion is at the cricoid ring. Okay, narrowest portion is at the cricoid ring. You have a large tongue, okay, as compared to the small mouth. Here you have a small tongue and the mouth is large. Okay, the heart has a limited functional capacity. Stroke volume reaches up to 2 at low feeling pressures. Cardiac output in very young children is almost entirely dependent on the heart rate. So remember your pediatric physiology. Okay, cardiac output is dependent on the heart rate. Okay, so if the child wants to increase its cardiac output, it has to increase its uh, the heart rate. Okay, so for example, from a rate of 120s, it will increase to 140s just to compensate the blood loss. Okay, in the adults, what will the adult do to increase cardiac output? Two things. Number one, increase the heart rate, and second, increase the cardiac contractility. Okay, meaning it will exert more effort in pumping. Okay, in a child that does not happen. Okay, there is no increase in cardiac contractility, only increase in the heart rate. So this would tell us that the child would have a weaker compensation. Okay, blood volume in the infant is 100 ml per kilogram. Okay, in a child it's 80 ml. In an adult it's 70 ml. Okay, so this would mean that if the child or if a child and adult loses the same amount of blood in ratio and proportion, okay, the child has actually lost more already. Okay, so we've discussed this. Physiologic response to hypovolemia is only increase in heart rate. Okay, the thin abdominal wall, okay, provides little protection to the abdominal organs. I think these are just repetitions. Okay, but here it's very important. We hear this. You will hear this in your radio lectures. Okay, what is SIWARA? Spinal cord injury without radiographic abnormality. Okay, so this is very special in children because the skeletons are still very compliant. Okay, so you don't see any fracture. Okay, because that is one of the things that you look for. So there's no fracture. Okay, but the child may have clinical symptoms. Okay, like the child is already quadriplegic. Okay, or there's a diplegic. Okay, so that is your SIWARA. Okay, we've discussed about compliant ribs. Okay, normal pediatric vital signs. A 1-month-old child would have a heart rate of 110 to 170. We don't usually take the blood pressures. Okay, but if we have the appropriate cough, okay, it's more than 70. Respiratory rate less than 50. Okay, so the younger the child, okay, the higher is the heart rate. Okay, let's skip this part. Okay, so the last part will be child abuse. Okay, and this is very important because this is one demographics of pediatric trauma. Okay, so child abuse, or what we call your non-accidental trauma. Victims of your non-accidental trauma present for medical care with a spectrum of trauma and non-trauma complaints. Okay, and as the physician or the doctors who will be seeing this patient, we have to recognize this. Okay, otherwise, what happens? Okay, for example, a child abuse case comes to the emergency room, and then we discharge that patient because we believe the father who said the child fell from a bicycle accident. Okay, and we discharge that patient. We did not suspect child abuse. What happens? Okay, there is a tendency for repeat attacks. Okay, you have emboldened the father. Okay, because he said that doctor is stupid. He doesn't know how to. Uh, he was not able to recognize, okay, that I was abusing my child. Okay, so there is a tendency for repeat attacks. Second, there's a tendency that the second attack will be more severe. Okay, probably the first one was just a contusion. The second one will now have a fracture. Okay, and I've not placed it here yet. Okay, but another uh, possibility is there is a tendency for the attack to happen in a second child. Okay, so for example, it's just one child now. Okay, later on it will involve the next child, and then the next child, and then the next child, until as doctors we are able to identify child abuse and break the chain. Okay, so there was this. If you've heard this in the news before, can you excuse me a while? Okay, sorry about that. So there was this story of a girl before, okay, who was repeatedly being raped by the father. Okay, and she kept quiet. She did not tell her mom. She did not tell her siblings. Okay, so she kept quiet. When she turned 20, and now the next, her next sibling was around 14, the raping stopped. Okay, so she thought it finally stopped, only to find out that her father is now raping her sibling who is 14 years old. Okay, so this was the only time that she talked. Okay, so this was the only time that she talked. So if you look at that, okay, there's a tendency for it to be transferred to the next child. So that's why we have to be very good at identifying child abuse. Okay, young children are at increased risk of significant morbidity and even mortality from child abuse. Okay, what are the alarm bells? Okay, number one, delayed medical care. Okay, that is why I said it's very important to identify the number of hours after injury. Okay, so for example, you have a fracture, okay, and the father only brought the child on the seventh day post-injury. That's an alarm bell. Okay, you know, doting parents, okay, even a small scratch, they will bring their child to the emergency room. Okay, and here is a child with a fracture being brought to the hospital 7 days after injury. So that's an alarm bell. Injuries are not consistent with the history or the patient's developmental stage. Okay, for example, a baby who is still crawling. Okay, a baby who is still crawling has a femoral fracture. Okay, the father said, "Doc, the baby crawled down the stairs." Okay, so that becomes an alarm bell. Okay, unexplained bruising or oral trauma, non-ambulatory patients are of course at increased risk, and special children are at increased risk. Okay, patient with autism, patients who are mentally retarded. Okay, these are special children. They are at increased risk, sometimes secondary to your caregiver fatigue. Okay, so the parents are tired of taking care of this child, and they abuse, okay, the child. Okay, so 80% of children that die from abuse are under the age of 4 years old. Okay, there are specific patterns of injury. Okay, like if you look at this picture, okay, the story of the parents was the child was running around and hit the ironing while the mother was ironing, okay, the clothes. The patient hit the ironing board and the iron fell. Okay, if that's the case, would you see would you see an injury like this? Okay, it's just like the mother press the iron on the child. Okay, we've seen a patient like this. Okay, with multiple burns. Okay, these are multiple burns. Okay, and what is happening to this child? The father is using the child as an ashtray. Okay, so every time the father is angry at the child, okay, he burns the child with his cigarette. Okay, so that's child abuse. Okay, red flags for abusive fractures. You have multiple fractures, especially fractures in various stages of healing. Okay, so when we suspect abuse in a child, we do a complete skeletal survey. Okay, do a complete skeletal survey. Okay, and identify. If you identify several fractures in different various stages of healing, that's a red flag. Okay, so here are the other possible injuries. So child abuse crosses all socioeconomic and educational levels. Okay, so it does not only happen to the poor families. Okay, it also happens in the high social economic status. Okay, it's just that we don't see it being reported in the high socioeconomic status. Okay, probably these families have doctors who come to the house. Okay, and are paid a very large amount so they can keep quiet about the abuse. Okay, so if you suspect it, you document it completely. Okay, complete the radiographs and laboratory tests. You refer to women's desks, women or children's desks, and refer to authorities. In hospitals, you don't need to refer to authorities. You just refer to children's desk, okay, and the children's desk will do their investigation, and they can be the one to report to the authorities. Okay. Don't ask yourself, Doc, what if I'm wrong? I will be shaming myself and shaming the family. Okay. Ask yourself, what if I'm right? Okay. What if you're right? Okay. So you're going to save the life of a child. Okay. We also have cases of sexual abuse. Okay. This is a personal patient of mine when I was still in fellowship. Okay. She was a 7-year-old girl. They live in the garbage dump. Okay. Or you call what we call the Smoky Mountain. Okay. They live near there. Uh, and so the family was already attuned to the child leaving off early in the morning, then coming back in the afternoon. Okay, the child would go looking for garbage that they could sell. Okay, but when the child did not get home for 3 days, that's when they reported. Okay, finally after a week, they saw the child walking, and there was bleeding in her underwear. Okay, so they brought the child to PGH. Okay, and this is what we saw. Okay, there was a stone in the patient's perineal body. We did an X-ray. Okay, so this is what we got from the perineal body. So we had to repair the vagina and the anus. Okay, vaginoplasty. We did a vaginoplasty and an anal repair. So this was a patient of sexual abuse. Okay, so of course we have to give psychological support to our patients with pediatric trauma. Okay, children are not mature enough to cope with this stress. Okay, and they can go into behavioral regression and even long-term psychological problems. Okay, so they will begin to have trust issues, okay, and probably never marry when they grow old. So some maneuvers will be to attempt to win the child's confidence with gentleness, non-threatening approach. Okay, have parents around. Okay, but if the parent is the suspected perpetrator, okay, uh, then usually it's and usually with abuse, okay, it's usually a member of the family, someone they trust. Okay, like if it's not the father, it's an uncle, it's an auntie, it's a grandfather. Okay, so we have to be mindful of that already also. Okay, so that is my last slide. Are there any points that you want to be clarified? Any questions? Okay, so the important summary for this lecture is, of course, children, okay, are at risk for trauma, whether this be or accidental, secondary to vehicular crash, or accidents at home. Okay, but especially for children, we also talk about your non-accidental trauma. Okay, and these are your child abuse. Okay, you don't expect much abuse in the adult group. Okay, of course, the adult we do have. I'm not saying it does not happen in the adult group. Okay, but I'm saying that the pediatric population is especially at risk because number one, they cannot fight back. They cannot tell a good story. Okay, if they are still nonverbal, they cannot tell their yaya shook them. Okay, remember your shaken baby syndrome. Okay, they cannot tell my yaya shook me. Okay, so that is why children are especially at risk. Okay, uh, the approach to trauma is almost the same as in an adult. Okay, but of course there are some special considerations. Okay, and the ones that I presented to you are what is my emphasis. Okay, so there are physical attributes that makes trauma in children different. Okay, like a very large head, very thin abdominal wall, compliant skeleton, the non-capacity of the heart to increase strength. Okay, so it can only increase the speed of its compression, but not the strength. Okay, so all of these contribute to the differences in the management of a patient with trauma. Okay, so if there are no more questions, or if you can think of a question, you can always post it in our Google Classroom. Okay, so let's have lunch. Thank you very much.